Okay, welcome everybody to this, I think it's the last session, yes, of today. And this is a session, it's a sponsored session by Boston Scientific. Title is Optimization of your valve implantation to ensure lifelong outcomes using a novel self-expanding valve. And before we start, let me say a few words about the panelists here. We have, unfortunately, two people who are missing because of some cancellations due to flights. One Kyung Kim and Joanna. But I'm still surrounded by a great panel. We have Raj Makar, as everybody knows, from Cedar Sinai. We have David Hildig-Smith. We have Fadi Sawaya from Beirut, and we have Andreas Ruk from Stockholm. So I think before we start, I want to give you a couple of objectives of this session. So the learning objectives of this session is indeed to understand the importance of valve optimization post-implantation. Probably many of you have already heard about the ACURATE IDE trial, so we want to deep dive a little bit on that ACURATE IDE trial and what the learnings were from that trial. And we think that's important to secure acute and long-term outcomes. We also want to understand some new features, implantation technique and benefits of the ACURATE Prime platform, and this is going to be associated with a live recorded live in a box case from Stockholm, from Andreas. And then we're also going to discuss how different TAVI platforms perform when treating larger annuli. Fadi is going to take care of that, and then other complex patient subsets. That's up to David. So I think with that, with no further ado, this is about. I think we're going to tackle on this. This is the ACURATE Prime, of course. This is the newest platform from the ACURATE Neo 2. Now we have the ACURATE Prime, which is available in Europe since 2-3 weeks. There are a couple of new iterations on this valve. I will not go into detail there. I think Fadi is going to talk about this still. And then also with the ACURATE Prime, there came now the option to have the extra large valve. So that's going to give us the possibility to treat even larger anatomies. So with that, with no further ado, I'm going to invite Raj. Yes, Raj Bakar. You're going to tell us the results and the importance, the results of ACURATE IDE and what we learned from this trial.
Thank you, Ole. All right. These are my disclosures. All right. So I think I don't need to tell you because you've been using this valve more than I have, and this valve is available in 50 countries, and there have been more than 80,000 implants with the ACURATE platform, and the results have been pretty good. If you look at the results from these observational registries, the all-cause mortality, stroke, rehospitalization rates, pacemaker rates, gradients, low PV leak rates. This is what actually has been seen, and the goal of the ACURATE IDE study was to do a pivotal IDE study for approval in the United States. And what we did in the trial was basically compare the ACURATE Neo 2 versus the commercially available valves in the United States, and not all commercially available, but select commercially available valves, which is the Sapien and the Evolute devices. So this is a valve that has a self-expanding nitinol frame with a top-down deployment. It's an open cell design with axial stabilization arches, and I think this wide open cells are amazing in terms of coronary access, and predictable commissural alignment can be attained if you follow the steps. And then, of course, the fact that it is supraannular, affords you really good hemodynamics. And there is a dynamic sealing skirt, which is designed to reduce the PV leak. There are 3 different sizes. Ole will talk more about that. But let me come to the ACURATE IDE trial. This was essentially a prospective, multicenter randomized study of 1,500 patients with symptomatic severe aortic stenosis, where we randomized patients 1-to-1 to ACURATE Neo 2 or to a mixed control. And the mixed control included different iterations of the Evolute and different iterations of Sapien, Sapien 3 or Sapien Ultra as they became available commercially. So there was actually a mixed control, and you had to pre-specify the valve type, and so patients were randomized. That was one of the factors as how the patients were randomized, depending upon what the control was. Mike Reardon was our co-PI, and these are some of the top enrolling sites. But these are the inclusion criteria, so I think these are very standard inclusion criteria. But one of the things that we also had was, in addition to the gradients, if an aortic valve area, you could also get the patient in to the study with the Doppler velocity index less than 0.25, even if the gradient was actually low. And of course, the plan was to include patients with annulus size between 21 and 27 millimeters. All of these patients, these are the inclusion-exclusion criteria, which are, once again, very standard, inclusion-exclusion. We excluded bicuspid aortic valves and patients with severe LV dysfunction. And, very relevant is the fact that we excluded patients who had stroke or TIA within 6 months. This is very standard for most clinical trials. It was a non-inferiority design. We assumed that the event rates would be 22%, and the non-inferiority margin was pre-specified at 8%. So, with a 1,500 patient sample size, we expected very robust power of 90%. This is the trial enrollment. As you can see, the enrollment was affected because of the COVID. So it took a solid 47-month period, as you can see. Early on, we enrolled extreme risk patients and intermediate risk patients, and then the low risk patients were actually enrolled as the amendment was made to the protocol to include the low risk patients. These are the enrollment metrics, and I think this may be relevant because, the enrollment cadence was a little bit prolonged, and the number of patients done per site was actually not so high. If you go by per month, so only 4% of the sites actually enrolled more than one ACURATE neo2 patient per month. So here is the randomization scheme, as you can see. At 1 year, clinical follow-up was available in 91% of the patients in the ACURATE group, and similar numbers in the control group. So these are the baseline characteristics. Essentially, as you see, the average age was 78. The STS is listed there as 2.7. And interestingly, if you look at the spread of high risk, intermediate risk, and low risk, it is not exactly 1/3, 1/3, 1/3, but roughly 1/3, 1/3, 1/3. And these are very standard inclusion, and they were fairly matched between ACURATE neo2 and control group. So these are some of the procedural characteristics. If you look at the procedural correct positioning of a single valve, they were actually similar between ACURATE neo2 and control. Conversion to open surgery, not statistically different, 0.8 and 0.3. Predilatation was mandatory in the clinical trial, so we did it in 99.6% of the ACURATE patients and only 1/3 of the control, where it was left to the discretion of the operator. Importantly, I want you to notice that post-dilatation was performed 26% of the times in ACURATE neo2 and 11% of the times in control. So these are the 30-day outcomes, and when you look at these outcomes, they're not very different. Whether you look at death, they're statistically not different. Numerically, they are a little bit higher in the ACURATE neo group when you combine death, stroke, and rehospitalization. But looking at individual endpoints, they are not statistically different. The rates of pacemaker implantation was 8.6% in the ACURATE and 9.5% in the control. And what I also want to point out is that when you look at the control, the breakup of the controls, you can see that 2/3 of these were SAPIEN patients and 1/3 of these were actually the Evolute patients. So this was the primary endpoint. Our primary endpoint was a composite of death, a stroke, and rehospitalization that was related to heart failure or due to valve-related issues. The probability, the estimates, the posterior probability estimates for the ACURATE group for this composite endpoint was 16.1% compared to 9.5%. So the difference was 6.6%. But the upper margin of the 95% confidence interval was 10.2, which exceeded what we had specified, which was 8%. So we were not able to establish the non-inferiority of the ACURATE neo2 compared to the control. If you look at the Kaplan-Meier analysis, so we have, all of these patients have completed their follow-up now. So, these are the Kaplan-Meier estimates. Once again, you can see that if you break it down into individual endpoints of death, there was not a statistical difference. There was a slight trend there, 5% versus 3.9%. But the stroke rates were 5.7% compared to 3.4%, and rehospitalization similarly. So death and rehospitalization were not statistically different, but rehospitalization was. And these things added up, in 1,500 patients, giving tremendous power, and hence the difference was easily observed between the two groups. So here are the other safety endpoints, looking at death, cardiovascular death, stroke. Once again, if you look at, there was increase in myocardial infarction. These were mostly non-ST elevation MIs related to enzymes. And once again, in fact, in terms of valve thrombosis, the incidence was actually lower with the ACURATE group. So here is looking at the death, and when you break it down, the cardiovascular death was different. It was higher in patients who had the ACURATE neo2 valve compared to the patients who had control valve. But as you drill down a little bit deeper, according to VARC definitions, any death that is unknown is classified as cardiovascular. So of course, I think we don't need to be defensive here, but just to put things in context here, that a lot of this was also driven by patients where we really didn't know the cause of death. Now, looking at the risk of stroke, once again, I think it's also important for you to break down the incidence into all stroke and disabling stroke. So the disabling stroke was 2% compared to 1.2%. Those are the rates for the leaflet thrombosis. So one of the thought process was, is it leaflet thrombosis that actually contributed to this? And those rates were actually lower. I show these stroke rates here to make the point that at 30 days, there was no difference in stroke rates. It was 1.4%, 1.4%. Okay, so I think it is something that happened after 30 days that accounted for higher stroke rates, which tremendously drove the primary endpoint. And this is rehospitalization, once again, largely attributed to worsening heart failure in these patients, but most of these patients who actually presented with rehospitalization did not have increased paravalvular leak that was at least moderate or severe. So here are the echocardiographic outcomes. I think not surprising, right? The hemodynamics of the ACURATE valve are more like the supraannular evolute valve. So if you look at the DVI, once again, higher compared to the balloon expandable SAPIEN valve. And if you look at the mean gradients, once again, they were very similar to the self-expanding supraannular evolute valve. These are the PV leak rates. I have to say that the PV leak rates are a little bit higher. They are actually higher for mild category. There's not a significant difference in moderate or severe, but mild PV leak was higher in the ACURATE group. When you look at the quality of life metrics, there was no difference in the NYHA class between ACURATE and the neo2 and the control group. Similarly, if you look at the KCCQ scores, once again, they're very, very similar between the ACURATE group as well as the control group. So I think the fact that we missed the endpoint caused us to look deep and hard as to what had actually happened, because we all left the cath lab feeling very good about the outcomes that we actually saw. And I showed you the 30-day outcomes. So we undertook a study and analysis to see what might have actually contributed. Of course, I think enough lack of adequate experience with this valve might have played a role. I think it is important factor. And one of the things that we observed was that 20% of the patients, as we undertook this analysis, had valves that looked not to be very adequately expanded. And, just to look at on a bench, what does that actually mean? When you have a non-expanded valve, it'll cause turbulent flow, reduced washout, and this might be something that might stage the set for for thrombi and so on and so forth. So I think, this is something that we are postulating, of course. And when you look at, did this lack of expansion actually play a role? The answer is, we don't know, but at least there is an association. What we know is that the non-expanded valves had a higher incidence of the primary endpoint, which is death, stroke, or rehospitalization. And specifically when you look at the incidence of stroke and death, it is actually higher. And if you were to do a theoretical exercise, it is of course post hoc, not pure, but if you were to do this and compare the outcomes in patients who had properly expanded valves compared to patients in the control, you can see how the properly expanded valves are much closer to the control cohort in terms of the primary endpoint. So I think in terms of the combined endpoint of death, stroke, and rehospitalization, we would still miss the endpoint, just barely. But when it came to death and stroke, the hard endpoints, we would actually be right on top of each other. So I think it is very important to put the footnote here that this is all post hoc, but I think nonetheless it generates a hypothesis for us to work forward and to actually make some improvements. And I think we've learned now how to actually recognize non-expanded valves, and Ole will talk a little bit more about that. But the analysis that we undertook essentially looks at the posts, and if these posts are not parallel, that's an important sign of underexpansion. And perhaps in these patients, we ought to be very aggressive in terms of aggressive pre-dilatation, of course post-dilatation, in fact, if you notice this, after this has been done. So one of the exercises that we undertook in a cohort of patients that we were still enrolling when we learned about this last year was actually the extended durability cohort. It's a small cohort, but nonetheless, after following this in a small number of patients, we showed that we could reduce the malexpansion rate by half, and we increased the post-dilatation rate from 20% to 50%. So something to keep in mind. And of course, I think the question about the opening force, radial force, hoop strength, all of those things are relevant, and I'm hopeful that the iteration in the next generation valve might actually play an important role as well. And these are a number of limitations, but nonetheless, I'm not going to have covered these in different ways. But these are the key takeaways. I think first and foremost, the ACURATE neo2 valve did not demonstrate non-inferiority to commercial valves for the primary endpoint of composite of death, stroke, or rehospitalization. 30-day outcomes, including death, stroke, new pacemaker implantation, or acute kidney injury, were not significantly different between two groups at 30 days. So valve hemodynamics, of course, were superior and as good as the Evolute valve and better than SAPIEN valve. There were no significant differences in quality of life outcomes and functional status. And of course, I mentioned about the post-hoc analysis and the role that we think malexpansion might have played. And I think it remains to be seen whether we can make a real impact on clinical outcomes when we actually eliminate the malexpansion using good pre-dilatation, post-dilatation techniques. Thank you.
Thank you, Raj. Maybe you can take a seat. I think the purpose was now was to get the talk from Juan, but unfortunately Juan is not there. So I think I'm going to take the place of Juan to give his presentation, and then after that we have a discussion about these study results, both from ACURATE IDE.
You want me to do questions?
Yes, please. If you have questions,
So Raj, there's a few questions. One, any difference in the antiplatelet, antithrombotic therapy post-TAVR?
No real difference between between antiplatelet therapy or anticoagulation.
Okay, and second question, should you bring back the underexpanded cases back to the lab for post-dilation? In order, now that you know this, are you bringing back patients?
We are not at this time. See, we don't know, right, what the impact is of post-dilating these valves 3 years later when these people are doing really great. So I think it's an open question, but right now right now we are not systematically bringing patients back.
Okay, good. We can talk about this for sure more. This is a similar topic. It's and this I give on behalf of Won Kim, who didn't make it because of flight issues. But it's under expansion topic again on the ACURATE Neo2. And as you see, so on the left-hand side, you see these are the results of the ACURATE IDE trial. So it unfortunately did not show the non-inferiority of the ACURATE Neo2. And this stands very much in contrast to the practice and the results we have in Europe. You see on the right-hand side, we have a lot of thousands of patients, ACURATE Neo2, where we actually show really good clinical outcomes with this particular platform. So why this discrepancy between these European real-world data as compared to the ACURATE IDE trial? Well, Raj already touched on this. There was an extremely robust root cause analysis within Boston Scientific with the help of some physicians, European physicians as well. And you see indeed that there was a clear association of these under-expanded frames. You see here on these curves what you see, indeed that's what Raj also showed. If you have a well-expanded ACURATE Neo2, actually these clinical outcomes fall together with a control arm. And that control arm, there was a mix of opportunistically chosen best by the physician, either Sapien or Evolut, that was not stratified. That's also important to say. So they had to compete with that. On the other hand, you see if you have an underexpanded ACURATE Neo2 valve, you have a twofold increase of mortality. You had a threefold increase of late stroke. That was the main issue, late strokes, that drove most of these rehospitalizations as the mortality as well, as you saw. So that was the main issue. And again, it's important to say what was the incidence of this underexpansion. Well, there was about 20% of patients. So we're talking about 20% of patients in this ACURATE IDE trial which had this issue. So of course, in Europe, we were triggered to see if this same kind of analysis could be done in the European populations. And I have to congratulate Won on this. He has a very large ACURATE implanter in Bad Nauheim. And what he did is he reviewed hundreds of European ACURATE Neo2 implants from his center and also from Copenhagen in Denmark. And the aim was to assess whether this same signal of mid-frame expansion and that association with worse clinical outcomes could be seen in the European population. That could be an extra proof of this root cause analysis. So the primary endpoint of his retrospective study was all-cause mortality, stroke, and rehospitalization. So again, what was the definition of mid-frame underexpansion? This was when we saw this non-parallel post. This is based on bench test work. We know that if we have an ACURATE implant with a non-parallel commissural post, this is due to an underexpansion of the mid-frame, the upper crown of the ACURATE. If it has to deal with a lot of calcium and it was not addressed with post-dilatation, we know that the valve looks this way. So what was the main data of this study? I can show here. So we see, first of all, there were 604 patients in this European retrospective cohort. After pre-dilatation, also there, I think we have to discuss a bit more, Raj, afterwards. But there was, as you showed, 99% of pre-dilatation in the ACURATE IDE trial. But I think we really have to question whether these were effective pre-dilatations. I mean, it's not because somebody takes a balloon, a random-sized balloon, 18 or 20 milliballid balloon, whatever the anatomy is, that we can call this an effective pre-dilatation. So I think in Europe, or the higher volume users of this ACURATE platform already knew a bit more that we have to kind of follow the IFU and have to go more for a perimeter-derived mean -1 or maximum -2 millimeter pre-dilatation to have a proper pre-dilatation. You see, when you're following this, you still had in around 16.6% of cases after the valve implantation and the release of the valve, there was some underexpansion. Luckily, in half of these cases, this was also seen and detected by the implanter, and this was addressed with the post-dilatation. So first of all, 16.6%, it was detected in half of the cases. And the good news is, if you see the underexpansion and you use a post-dilatation in more than 90%, 92% of cases, you can actually address this issue and get to a well-expanded valve. Yes? That makes that in this retrospective European cohort of ACURATE neo2 implants in 2 large volume centers, we have 9.4 under-expanded ACURATE neo2s to compare with 91% of well-expanded valves. So that's what this whole analysis goes about. Well, first of all, we see that there was more use of post-dilatation, of course, in the well-expanded valves, much less in the under-expanded valves. We also see that, again, the technical success was actually really good. There was a little bit higher severe PPM rate in the under-expanded, in the valves with under-expansion. And then there, the primary endpoint, of course, showing exactly the same results as in ACURATE IDE. If we have a valve, an ACURATE neo2, which is under-expanded, we see again that this is related with more mortality and also especially with more stroke. Yes, so we see exactly the same signal. Again, this was in a smaller cohort of the population in 9.4% versus 20% in the ACURATE IDE trial. But again, this is kind of a repetition of the and a proof that this root cause analysis makes sense. Also important, as I said, in these 100 evaluable patients with initial mid-frame under-expansion, 94 patients underwent post-dilatation, so almost 1 out of 2. 92% you could get this under-expansion resolved. And what is even more important, if you correct for these patients which had an initial under-expanded valve, but you address it with post-dilatation, you see that these clinical outcomes also are excellent. They fall to the exact same level and the same good clinical outcomes as the well-expanded valves. So that's reassuring. That means that there is that issue of under-expansion if we don't have a proper pre-dilatation maybe, or sometimes there's such a calcified environment of calcified leaflets. But if we see the under-expansion and we address it with post-dilatation, we can correct and take away the issue. So in summary, in this European cohort from 2 experienced centers, mid-frame under-expansion occurred in 9.4%, ACURATE IDE 20%. The rate of mid-frame under-expansion may vary according to the applied methods. It was associated as well in this retrospective cohort with increased rates of all-cause mortality and stroke at 1 year. It can be identified during the index procedure, as Raj showed nicely. It's mandatory to use, for sure, 2 fluoroscopic views. And no post-dilatation and commissural misalignment were independent predictors of mid-frame under-expansion. Rarely, pre-dilatation may not be required, but I would say as an ACURATE implanter, I'd use it in 99 to 100%. I try to go for a proper, effective pre-dilatation. And it's important to know that if we have under-expansion, that post-dilatation effectively mitigates this issue of under-expansion and thereby also improves clinical outcomes. So I think with that, I think this was the last slide from 1, never cross the beams. So if we see these non-parallelity of the posts or these other 2 signals, a trapezium-shaped inflow part of the body stent, we have to address this with post-dilatation.
So Ole, there's a question. So if you see no gradient and no PVL, so single-digit gradient, no PVL, and you see this post, non-parallel post.
Yeah.
So what's the new practice after the IDE trial for you guys?
Maybe we can ask Raj and David as well. I mean, I'm happy to answer on it, and Andreas too.
I mean, right now we're not enrolling, in the ACURATE IDE. But what would I do? Right?
And what do you do with other valves?
So I think so. The issue of mal-expansion is not just important for self-expanding valves. Maybe it is more frequent. But I think it is also important. There's literature now. For example, we did analysis in the sapien valve and bicuspids. And what we observed was that if you have mal-expansion, there is an increase in similar endpoints. So I think this is going to become, I think there is a shift now for all valves. We were all driven just by gradients and paravalvular leakage. And I think now we are going to pay a little bit more attention to the valve frame expansion as well. And that needs to become integral into our practice. So I think, looking at the valve in different views, not just one view and getting out, deploying the valve, is going to become very, very important. And I think with a valve like ACURATE, I think if you routinely do commissural alignment, you are forced to. You're going in different views, and you are more likely to pick it up. I think if if we had to do an ACURATE IDE study, again, I would mandate that you have to try and do commissural alignment, which is not something that was routinely done.
Yeah. David, any learnings here from you? In your own practice now?
Yeah, I mean, I slightly think that the focus purely on expansion of the valve and, oh, that's the only problem, therefore if you fix that, everything else goes away, is a little bit of a mistake. You know, every valve is underexpanded to a certain extent. No valve gets to its actual sort of market size, if you like. So, you know, we have to look at this and be memorizing this for all types of valves, and the underexpansion only happens because the preamble to it hasn't been adequate. So I think if you just focus on underexpansion and say, oh, that's the problem, and that would have fixed things, I think that's rather missing the point here. The point is potentially many reasons why the trial wasn't as good as hoped. You know, there was no physician proctoring to run the cases. Possibly some of the cases were a bit more calcified than was really ideal for this platform, and I think if those had been taken into consideration and a full adequate pre-dilatation had been done, which perhaps the operators were not entirely familiar with the necessity because they're not used to using a platform with slightly less opening force, then overall the results would have been better and we wouldn't have been focusing quite so strongly on this single topic of underexpansion right at the end.
But you know, the average balloon size was 22.6 for pre-dilatation in the in the IDE study. Now, it was 22.6, and for a lot of people who are not used to this valve, right? Because they're used to putting core valves or evolute valves without any pre-dilatation, and of course, the same is true for that. So I think for a lot of operators, they thought they were doing a good job, and the average size was 22.6 millimeters. I think you are right about this. So what we have is an association, not a causation for sure, right? And I think we need to. We need to prove it, but I think it would behoove us, if we can safely expand these valves, we should safely expand these valves rather than leave the cath lab with a improperly expanded valves. And I think you have to, in some cases, weigh the risk of, when you do multiple dilatations, you might also have increase in stroke rates and other things, and aortic root injury. But I think we can definitely, I think the fact that experienced operators, the two of the most experienced centers, that's the data, and you have 10% under expansion, I think we can do better. From 20, we can move towards 10.
That was without the knowledge of the ACURATE IDE, of course. There was no systematic screening for under expansion, although I don't want to put the focus on
but I think what we want to give to people is that it is important to look at the valves and at least assess valve frame expansion, and then in your good judgment, if you think you can safely do a good job and expand it well, you should.
Yes. Okay, I think due to the sake of time, we have to move on. And I want to invite Andreas Ruk, colleague and friend from Stockholm. You have a nice recorded case for us.
Yes, thank you very much for the invitation. I would just state first that maybe we don't need to overcomplicate things. If you have a properly sized pre-dilatation balloon, why not use it again? That's a simple way of seeing it. Maybe even doing it routinely. We don't do it routinely, but that might be a quite simple solution to the problem. So, thank you for the invitation. First, just a couple of slides on the patients that we treated. These are my disclosures. The background, the 77-year-old male, ischemic heart disease, cabbage. 14 years ago, one of the venous grafts has occluded, but it was decided nothing needed to be done about it. Native 3-vessel disease, diabetes, hypertension, atrial fibrillation. So probably not a good surgical candidate. He was recently hospitalized with heart failure, discharged on the echo. We found the aortic stenosis with a Vmax of 4 meters per second, mean pressure gradient 38, calculated valve area 0.8 square centimeters, and a slightly decreased LV function, 48% EF, normal kidney function. Not uncommon patient, probably. ECG, nothing special. Here you can even learn a few Swedish words if you read there. Q restoration 80 milliseconds. CT analysis, you will see that it's a tricuspid valve. It has been discussed if this product is only suitable for low calcification patients. We don't really think so in our center. We use it quite broadly. I can't say that everybody should do it, but we use it in much more than half of our population. The calcification score here, calculated on the native scan, 3,200, so actually pretty high. Annulus 26.7, coronary heights are good, and I'm showing the two calculated views that we always calculate since a couple of years already for the commissural alignment. But as said, that will help you also detect underexpansion during the case. No problem with the peripheral access, 8 millimeters spotty calcium in the femorals. Procedure goals in this specific patient, since he has heart failure and the decreased LVEF, it's important to achieve a low gradient and a high opening area. We don't want to cause a new pacemaker, and because he has coronary disease, we want to preserve coronary access. Procedure plan, access right femoral with the 14 French eye sleeve, which is the same sheath for all sizes, pigtail from the left radial. We don't insert a temporary pacing lead in these patients with a narrow QRS because the risk of causing an AV block is extremely low. We will predilate with a decent size balloon. It's in our case we use true balloons for all these cases. It's a 26 in this case, which is then 0.7 millimeters under the calculated annular size. And for the prosthesis sizing, we chose a 29 millimeter from the Prime platform, the XL. As you see here, we're a little bit in the gray zone between the 27 and 29 millimeter prosthesis, and as a general rule, then we upsize to the larger size.
Welcome everybody to Karolinska University Hospital, where today we'll show you a case of the ACURATE Prime prosthesis in the new extra large 29 millimeter size. I'm Andreas Ryck. To my right, I have my colleague Rickard Linder, and I'm assisted by our crew here in the cath lab at Karolinska in Stockholm. So this is a 26/7, and on the ballooning, we know from the previous generations of the ACURATE valve that pre-dilatation is important, and here at Karolinska we have stuck to the principle of just downsizing around a millimeter in size from the annular size to the balloon size, and we always use non-compliant balloons. So that's for this patient, a 26 millimeter balloon. You agree on that choice, Rickard? Is it something you would do too?
Absolutely, and the big good thing about it is that we can use it for post-dilation if needed too.
So in the ventricle we have a safari wire, lies nicely curled in the outer curve of the aorta. Not so important maybe the wire position for the balloon, but then for the valve we prefer to have it in the outer curve. Okay, is the pacing ready? Pace on? Yeah.
Yeah, that's better. That's better. Yeah,
okay, good.
Yeah,
balloon up. Balloon down.
Oh, I tried to stop the video. I did, but this is just to ask here on the podium, is the pre-dilatation good enough?
No. Because the balloon was in the aorta.
Good. And then I'm trying to get the slides back. Everybody agrees now since a couple of months. I mean, at Karolinska we've been preaching about balloons for years with a quite low number of followers, I would say, but it seems to have been increasing a lot in the last months.
Welcome everybody to Karolinska University
maybe
Hospital.
I can jump forward here then, I hope so.
We'll show for this patient a 26 millimeter.
Yeah, but clearly, if you have such a balloon inflation, that's not an effective predil, of course.
Yeah, that's better. That's better. Yeah,
okay, good.
Yeah,
balloon up. Balloon down. Pace off.
Quite hit it.
Pace off.
Good enough.
Pace on.
No.
Actually, there is a third time, but it was cut out of the video.
Okay.
So we agree. We are quite thorough with the predil. Yeah.
There it comes.
Yeah.
Okay, balloon up.
And maybe it's this one. Yeah.
That's better.
It's still
You got some of it that time.
Do you always use non-compliant balloons? True balloons?
Yeah, we do that, but for some reason it's quite rare. We noticed also in Europe to use it true.
So I hope you did, because if this were the two balloon inflations, I wouldn't consider this as an effective predil.
Agree.
Yeah.
Message taken. And there is a third one which was, edited out for time reasons.
And that was the effective one.
It seems. We'll have to judge it after we implant the valve. So here comes the Prime And I think there will be sound too, which we insert over the wire through the 14 French.
Both quite quick.
Is the sound recording off? Maybe.
With a high success rate, because there are lots of markers on
So
the
your
system.
wire is, maybe you can comment on that too.
Yeah,
It's
the wire should be out the curve. There is some discussion on which size Safari you should use. I think it's an open question. We usually use this XS, the smaller one of the two that are available. And now we come down to the annulus, and here is important, and now starts before we go down with the marker to the depth, the intended depth, we put the marker at this position at the top of the pigtail, and then we do the commissural alignment in 2 different views, which are pre-calculated per patient specific. So usually we start in the REO view, which I think this is, and then we want to have one isolated stent post towards the inner curve of the aorta.
Because this is also new in the Prime, yes. So in the ACURATE Neo2, you had some kind of a free cell that's not there anymore. It's now part of the body stent. So the valve has some more real force, but they made some other markers. Maybe you comment on that.
Yes, so these 3 rods that stick out just over the nose cone, these are quite useful actually, and we find that they actually work even in rather heavy patients if you have a decent fluoro system. So we see them in almost all patients. Then higher up on the valve frame, there are other markers, the commissural posts, which you also see, same as before. So maybe we can turn the sound on from the recording, and then we'll talk over it, I think, from the recording.
View to see how it appears there.
So this is now the cusp overlap.
This is the cusp overlap,
Inner
exactly.
side of the aorta,
So this is a correct alignment on the cusp overlap, but the exact orientation can be fine-tuned in the 3 cusp.
Of the wire on the lower part. So if you go back to the... so we're actually not far away from the ideal.
So usually you pre-program the 2 angulations in the beginning of the procedure, then it's just press a button to switch back and forth. It's really quick.
Andreas, do you want to turn clockwise or anti-clockwise in this appearance?
So there are a couple of rules, but the simplest to remember maybe is to look where you have the isolated stand post or the rod down, and that's to the left side, so we rotate towards the left side, meaning a counter-clock rotation. Agree?
Yep.
Okay.
Because
if you turn the wrong
you're
direction,
back
you will
in tricuspid planar view, so you want to have a 1-1-1 pattern.
Exactly. Here, one of the rods will be superimposed with the wire, which is straight in the middle, and then equal distance to both sides. Then you have the perfect alignment. Then it might still rotate a little bit up on release, but that's how much you can control.
And the marker that is just above the nose cone there, that's higher than we're used to. Has that changed with Prime then, or is it?
It's just a shorter marker.
Yep.
It used to be 2 millimeters high, now it's 0.8 millimeters.
Oh, okay. Now it's down at the annulus.
Yeah.
Same
position, but it's
same positioning.
Shorter.
Yeah.
Starting to rotate knob number 1.
So it's a gradual release. This is the same as before. So the middle part, the upper crown, comes out first. Here you can still reposition up, down as you like.
That looks very nice.
Most people will say this is a pretty good position. And then you continue. What you can't do with this valve is resheath it, but in this stage you can go up and down during this stage if you like to.
Will centralize a little.
What has been debated a little bit is how important it is to correct for any parallax, but maybe that's beyond the scope here. But we don't seem to have a lot of parallax here, so that seems to be good.
You happy for me to take
Yes,
the
pigtail can go.
And then it's maybe important to keep an eye on the second operator there on his hands. This is brand new on the
Yeah,
Prime.
this is the wow moment where it's just a quarter turn to release. So it comes out, actually, we checked, it's 1 frame open, 1 frame, or 1 closed, and the next one is open. So that's really fast.
Yeah.
If that really translates to a difference in the final expansion, we're not sure. What I can say is that we used over 50 primes now in our center, and it seems like the frequency of leaning posts is lower, probably because the reinforcement in the metal is just under the posts. Makes sense.
And the valve didn't appear to move at all as it's opened there.
Yeah.
You know, it looked very stable.
Yeah.
Is that how it's behaving?
Yeah, it is.
It is, to be honest, true that sometimes with the ACURATE Neo2, if you put it at 7.5 frames per second, your fluoro, that sometimes with the expansion, you saw like in 2 different frames, that you saw like a stacked opening.
No,
you don't have the chance to see this in the Prime, because it's just extremely quick.
So now comes a rather lengthy evaluation, but the point is to look at the stent post. So maybe the question to here to the podium, is the middle one parallel or non-parallel? or in between? What do you think? It's just fluoro now, but is it
Probably all right, isn't it?
The cine.
Quite good.
quite good?
Yeah, looks fine.
Maybe not perfect. I don't know exactly what the rule of Kim was on exactly how much it could deviate. Can you tell us?
Yeah, well, that's about if you put a virtual line through the post that they would cross. Yes.
Within the frame.
Within the frame.
Within the frame. Okay.
And that's not the case.
Then it's good.
So I think we also have to look at the inflow and the expansion at the level of the upper crown, in addition to the posts.
Yeah, so here we're reviewing the images to see any under expansion, which we don't see. What we can say is that the commercial alignment is about 25 degrees off, maybe 20 degrees off. We'll see that in the later images. So here, ideally in this picture, you would have one isolated post to right, which we have, but the two on the left should be superimposed, which they are not quite, but still within the range.
Yes.
Here, echocardiogram, mean gradient 5, so no signal of any problem there. Nowadays, we have an echo technician in the cath lab, so we have a quite thorough echo evaluation of each patient. And we see a little bit of a PVL there, but of course, we have something across the valve too. But this on this position, I think it's probably PVL and not transvalvular from the catheter that we still have across. And we will then, in a little while, also take a root shot. This is just other images, short axis image, a little bit of PVL, but looks like trace here on the echo. And here comes the root shot. Yeah. So, probably good, I think. We don't see any PVL. I think it's quite new to us since we have a brand new echo machine and echo technician that we even see more leak on the echo than on the autogram. It used to be the other way around.
And this was the XL valve, yes? So
this is the 29 valve. In quite heavy calcium, so it's...
So, and
the engineer says it's stronger, so
yes,
it's probably right.
Is that your impression, that it is stronger? You know,
yes.
Clinically, you feel that?
Yes, but we shouldn't jump to the conclusion to say, oh, we don't need to post-dilate anymore. We still post-dilate about 25% of those, but we used to post-dilate over 50% of the Neo2s.
Yeah.
Yeah.
That's maybe also because of your better pre-dil. You do it systematically now, a real maxed out pre-dilatation. Yes.
Yeah, and now we apply these 3 rules, for under expansion, which we didn't apply before in the Neo2 times and until recently. So, yeah.
So, Andreas, I think, you saw that AI and you thought that was trace to mild or mild, or you thought that was related to the way the Nyquist was set. I mean, your angiography was convincing. I agree. The question is, in the post-ID world, would I be tempted, or should you be tempted to go and post-dilate, and despite the fact that you look good?
We discussed that too, because of course anything that we see can be improved by simply reusing a balloon we already have on a table. It's really simple procedure and safe too.
I got to disagree with you there. I think, the post-dilatation isn't for free. I've seen more complications, but the balloon inflation is a dangerous time in the procedure. If you don't coordinate the pacing, as you didn't in that first bit, with the balloon inflation, you can embolize your valve, you can damage the aortic root, you can get coronary occlusion. There are complications that happen with post-dilatation, and everyone who does TAVI here knows it. So yes, post-dilatation is good, but it's not free. It's not.
But it's actually the same size as before, so it's kind of a double tap, So, yeah.
You can share with your experience. I think you do some, even in balloon expendable, some double tap implants.
That's much lower.
I mean, I think what we have learned is, because if you go with the second dilatation with the same volume, you can see how the balloon expandable valve nicely expands. So we've started doing that. Now we haven't, I don't want to say, we are carefully monitoring our stroke rates. When I'm doing a very heavily calcified bicuspid where I know I'm going to pre-dilate and then do tap, 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 maybe, I definitely go ahead and use a sentinel. Of course, there's no data, but there I feel, that procedure is out on the fringe in the sense, it's a lot more intense. So I will go ahead and use the cerebral protection device. So, I think we are all learning right now how to make sure that we expand our valves better.
It is slightly different, though, with the balloon expandable system. You know, you have the balloon right there in the ascending aorta. There's been no exchange of equipment. You're not running the risk of going back round the arch, creating possible chance for stroke. So, you know, it's much lower risk, I think. We do the same.
I mean, Andreas, your valve was nicely expanded. You know, I think so. I think I think you did the right thing, you know, I think you were convinced with the angiography, and I think from a distance it looked good to me as well. So.
Okay, thank you.
Any questions from the audience?
Let me see. So somebody was commenting about the faster deployment. How often do you see valve recoil post-dilation? This is a question.
I mean, if one would measure it in every patient, I think it's happening in almost all patients with nitinol. That's just a property.
That's all valves.
But yeah.
And your post-dilatation, in which fluoroscopic view do you do this?
And which balloon size?
Yes, the balloon size almost always the same as predil, so annulus -1 approximately. And we almost always do it in the REO projection, because there you see the under expansion more, and then you see the full expansion of the balloon better.
Yeah. Okay, thank you. So I think we move on to the last part of the meeting. So Fadi, with that, I want to invite you. You're going to have a talk about different TAVI options in patients with large annuli.
All right. So we have now multiple options for TAVI with large annuli. We had only 2 options for years. We had SAPIEN 3, where we used a 29 millimeter, and then if it's beyond the recommended zone, you overfill your balloon. We have data where you can overfill up to 8-9 cc's. We had the Evolute platform, 31, then 34 millimeter. This was done for large annuli, and now we have the newcomers. You have the MyVal. You have they have valves at 30.5 and 32 millimeter, covering up to, we'll discuss it, a Titan 35 millimeter, and the Prime XL that Andreas showed now. So now part of the pitfall of the other valve that didn't have a large size, and now I think every company did a valve that will cover large annuli. So for the SAPIEN, you know, this is data from Kassel from Germany, showed that you can add cc's and you can cover up to 740. And if you look at the literature and a lot of case report, you have up to cases done 800 and 1,000, and you can add as many cc's as you want. However, you know, if the anatomy is very eccentric, you see more PVL with adding more volume. Sometimes you have central AI if you add more than 5 cc's, and we don't know what's the durability on the leaflets when you overexpand the valve. If you look at this bench study where they overexpanded the 29 millimeter valve, there was no problem with coaptation compared to 23 valve where you had mild coaptation, severe some central AI, mild central AI. But if you expand beyond 7, 8, you see it with the 29. From my experience, you start seeing central AI. Then we move to the Evolute 34. The Evolute 34 covers up to a perimeter of 94.2, so diameter up to 30. The frame shape is very important for the Evolute. You can see that the inflow is 34, but the waist is 24, so it's very hourglass-shaped kind of valve. And if you look at the data, well, the pros, it's the first self-expanding valve that covers up to perimeter 94.2. But if you look at the data, this is nice data showing that with the XL, you have higher risk of pacemaker. Even in the study, they look at the membranous symptom, high deployment, but they had pacemaker rate of 20%. And it's a bit more difficult to deploy because of the hour-shaped glaze. You have to put it high, you have to use the Lunderquist wire, and it needs a bigger sheath. So for the Evolute 34, you don't use the 14, you have to use 18 French equivalent or 22 French. So higher pacemaker, a bit more difficult to deploy, and bigger sheath size. And this is a nice study from Guy about the Evolute 34 in real-world registry, and what he showed that he compared 2 groups, oversizing less than 12% and oversizing more than 12%. And on the if you oversize less, so when you get closer to a perimeter of 90 to 94, the outcomes were not as good. And you had higher risk of mortality, higher risk of PVL, and higher risk of reintervention, so putting another valve. So there was more, so if you don't oversize much with this kind of valve, you have worse outcomes. And then we moved to the third platform. This is the MyValve. And the MyValve, they added these two valves, the 30.5 and the 32, addressing up to an area of 840, so 32 millimeter diameter. There's a lot of small data, and this is one data only for large patients, for 10 large valves, only 10 patients in this study from multiple centers. And what they showed, that also goes through a 14 French Phyton sheath, so the size stays the same, but you have to pre-dilate the sheath with the 18 French dilator. You have to, they're pre-dilated in 9 out of 10 patients, so this is another consideration. You had mild PVL in 3 patients. You had 2 patients who had pacemaker implantation, but everybody had the device implanted. So, and now they have, from the landmark trial, they had nested registry, and it's still getting completed. So we don't have a lot of data yet on the MyValve. We use it in clinical practice, but in the trials, we don't have an Excel study yet, but it's gonna hopefully be published next year. Then we move to one of the newcomers, the Navitor Titan. The Titan is a 35 millimeter valve. It covers up to 95 perimeter. Compared to the Evolute, you can see it's a tubular shape. The inflow and the outflow are the same, so a bit different design. It also goes through a 15 French delivery system, so lower French size than the Evolute. And really, there's not much published data. So I was trying to look how did they get the approval, and I couldn't find data published. However, part of the Navitor approval study, you have 90 patients that are being followed up, and hopefully it's gonna be published next year. This is from the US study. And last but not least, the ACURATE Prime, this is what Andreas showed. With the new Prime, now it's a top-to-down deployment, which makes things easier. You deploy it in one fashion. You don't have to worry about the height of the valve. And they added these connector cells that are gonna increase the opening force. And it's a consistent deployment. Commissural alignment is very easy to do. You look at the post and you look at the 3 markers. How Andreas showed it was super simple. And it's a deployment at 5 to 7 millimeters. So really, you don't have the difficulty that you have sometimes with the other self-expanding platform. So the advantages of this valve, it can cover up to 91. It also uses the same 14 French eye sleeve. It has a stable deployment and also has an unrestricted coronary access. So they got a CE approval based on this study from Australia. They had 13 patients and had good hemodynamic. 91.7% had none-to-trace PVL, and there was no moderate to severe PVL. So this was the initial data. And now this is presented for the first time in EuroPCR. They had part of the IDE trial, there was 50 patients from the nested registry, and you had continued access 39 patients. So now we have published on 102 patients with the ACURATE Prime XL. So this is the first data on this platform. And what we see that it's for whatever reason, it's a male-dominant population. Almost the majority are between high, extreme, intermediate, and some low patient. The mean gradient was around 41, valve area of 0.8. And if you look at the hemodynamics, they're excellent. You have a gradient of 6.6 at 30 days with effective orifice area of more than 2.1. So really good hemodynamics in this more than 100 patients. And if you look at the PVL, you have 88% with non-entrained, with 11.2 with mild. That increased a bit at 30 days at 17.5. If you look, there's 2 strokes at 30 days, no other real major outcome. That was surprising a bit. You had 6 pacemaker at discharge that became 13 at 30 days. So I'm not sure why this increased late. But however, this is the first real-time data showing very good outcomes of this ACURATE Prime XL. So why is this valve good in our armamentarium? Because one, it's the same deployment as the other ACURATE we're used to. It has a very large arches that will allow your coronary access. I think it's a very good initial valve, especially if you want to revalve in the future, because it has a short functional neo skirt. And if you look at it, you can deploy it at the upper crown or at the lower bottom of the commissural post, which gives you very good coronary access and coronary perfusion. And if you look at this platform, here we say that not all supraannular valves are the same because we deploy it at 7 millimeter, the neo skirt is lower than other. If you compare it to the neo skirt of an Evolute, it's way lower. This is an example of a 26 and a small, and you have a neo skirt of 18 compared to 23. So as a conclusion, now we have many technologies to address the large annuli. We have early data from the newcomers like Prime XL, which is very encouraging. The Prime XL will bring the same key feature of the New 2 platform with the ease of deployment, single-digit gradient, low pacemaker rate, easy coronary access, and I think it's an optimal valve for revalving. Thank you.
No, I think it's indeed an interesting topic, these large annuli. I mean, there's a lot of discussion and presentations about what to use in small annuli, especially after the SMART trial. There has been extensively discussed and large preferences for hemodynamics. But on large, especially now that from the major companies, you have now, there was for a long time only the option for Sapien or Revolut. Now we suddenly get more options. So I want to hear maybe your vision on that, Andreas, Raj, David, maybe some in the audience. If you have a particular strong opinion on that, please, there are also mics in the audience, I think. But Andreas, maybe first to start with you. If you see a large annulus, what's your first concern or what is your first thought you see?
Depends a lot. I think if it's in a bicuspid setting, maybe it's a slightly different discussion, although we presented earlier today a bicuspid study on the Neo 2, not on the Prime, which showed really good outcomes in 181 European patients. So maybe actually this valve works better than some people think in bicuspid patients too. But otherwise, for now, we treat annuli up to 29 also with the XL platform if it fits otherwise. So I think it's a addition, and I don't want to say anything bad about another platform, but it's good to be able to post-dilate up to a proper balloon if you implant a large valve. That's what I would say.
But are you concerned about how easy or the ease of implantation with particular technologies in larger anatomy? Sometimes we know it's more difficult to position a certain valve in a certain position for the larger annuli because of the stent frame design, for example. Is that, or the overexpansion that Fadi mentioned? If you go for adding 5-6 cc in a balloon, do you have any concern on this?
So I think we are very used to putting extra volume or lower volume and playing around with volume alterations when we actually do these cases. So I think it's important now, depending on, if you're in the United States, you have access to 3 different technologies. You have the Evolute, you have the Sapien, and now you have the Navitor Portico. So I think for us, if we think we cannot do a good job by putting in extra volume, then I think we will consider using either an Evolute or a Portico. And I think it all comes down to what is the platform that you use most often, right? But I think the other 2 platforms can also work well. I think what I like about the ACURATE platform is if you follow the instructions, it's easy to place.
Yeah.
All right, so I think there is no rocket science. If you just follow the guidelines and if you follow the steps, you will get a good placement of the valve.
That was even one of the signals. I mean, in ACURATE IDE, despite having very low experience with this platform, I mean, if you look to the 30-day results, these were amazingly good in a way, yes? If you could see, like, the operators had very little experience with this device, but despite that, the procedural outcomes were actually really good.
Yeah, I mean, the 30-day outcomes there were as good as anything, in fact.
Control. So, yes. David, any last comment on that?
What about large annulus?
Yeah.
Yeah, I mean, when we see a large annulus, I don't that much like the 34 millimeter core valve. I think it is a little bit difficult to use. So we really want to see anatomy that's suitable for the S3. If Prime changes things, that's great. But at the moment, for me, it's not a platform for the big annulus.
Okay, good. All right, so I think we're going to go to David, yes, as the last speaker. And you're going to tell us a little bit more about the versatility of the ACURATE platform, so in different subsets of patients.
Yes. So I'm going to say a little bit about the use, the versatility of this platform and how we use it anyway in my center. And I'm going to start with the weaknesses of the ACURATE Neo so we can get them out in the open and put them to the side. And maybe things will change with Prime, and if it does, that's great. But at the moment, when we don't have Prime, it's not the platform with the greatest opening force in the larger annulus. So this is a slight limitation of the valve. And similarly, it has less expansile force in severe calcification. It has to resist it, the calcification resists it back. Okay, so for us, that means that that's also not anatomically the best platform for this. Lack of repositionability, people sometimes complain about it, but you know, the S3 isn't repositionable and nobody is bothered by that. So let's move on instead to the strengths of the ACURATE Neo, and actually there are many. So for us, certainly it has felt for many years that the actual opening force in the smaller annulus is much more significant and more robust. So the smaller device has greater strength as it opens, and that means that its expansion is good, especially if you don't set it up against too much rigid calcification. The more rigid the calcification is, the less likely you are to be playing to the strengths of this valve, in my opinion. But the other really good things about this valve are that in contrast to some other platforms, there's a very stable position during deployment. And Ole just alluded to that with the very good results in the hands of people who hadn't been used to using this valve very much. You get excellent alignment. It sits perpendicular to the annulus. Importantly, you don't get any occlusive phase, so the hemodynamics are good. There's not a time when you're using this valve where the left ventricle is trying to eject the valve. That doesn't happen because the valve isn't open until that final moment when it pings open. And you don't lose coaxiality during deployment. There are other platforms, in which that is not necessarily the case. Coronary alignment is straightforward. Coronary access is excellent. So these are all strengths of the ACURATE Neo. And I want to mention one other big strength, which I think doesn't get mentioned quite enough, and that is that you have a big margin of safety in your deployment, because, and I think Andreas showed this slide, the maximum area of expansile force is not at the very base of the frame, it's 5 millimeters up. So this means that you have that margin, you sit just below the annulus, you don't have to target 1 or 0 or -1. You sit just below the annulus, you have 5 millimeters with which to play. So if the valve does move just a tiny bit, a millimeter, because of our incompetence or the intrinsic nature of the platform, that doesn't matter. You haven't lost anything. You don't risk device embolization or finding that part of it is supraannular. So this is an understated but very considerable advantage and strength of the ACURATE Neo. So for me, this valve at the moment is ideally suited for the smaller annulus with moderate calcification. So that's very commonly the elderly female. They may have fibrous AS, they may have AS with relatively limited Agatston scores, maybe below 2,000. And then there are other anatomies where this valve is in fact ideally suited but currently underutilized. A predominant and indeed pure aortic regurgitation, actually it works extremely well, and I'll come on to that in a bit. Horizontal aorta, of course some platforms are good, but some platforms are really not at all suited to the horizontal aorta. The ACURATE Neo is. Valve-in-valve procedures, as I'll show you a couple of, again, this is a very nice platform which avoids some of the pitfalls of having an occlusive phase of valve deployment. So let's show a few cases. So the very standard case in our place is female aged 80, smallish annulus at say 21, lesser calcium burden. This is about the standard case for us. You set up your angiogram, you have a cusp overlap view and then a 3 cusp view. This is in fact so old that it's the previous version before the ACURATE Neo 2 with the marker, and this was the probably the Amplat Super Stiff before the Safari was invented. And deployment of this valve in a very nice position in this kind of anatomy is absolutely routine, and it's our go-to valve for that setting. If you do decide you need to post-dilate it, as for example in this case, that is, as Andreas said, perfectly straightforwardly done. It's not zero risk, but it's perfectly straightforwardly done, and you can eliminate the aortic regurgitation quite successfully with that. So let's look at a couple of other anatomies where I think it's well worth considering using this valve. Horizontal aorta. So this is a case, I actually don't know if this was me that did this, but this is in our database at our hospital. I hope it wasn't me that did it. You will have noticed it's not an ACURATE Neo valve. Anyway, the operator, and it might have been me, but I don't know, was clearly struggling. And you can see that they're failing to get any kind of coaxiality and alignment. There's horribly off perpendicular, struggling to put in this valve. In a minute you'll see them trying again far too deep. This is going to be implanted at 2008 height if that one goes in there, and then you'll see in a minute the operator, something happens, and probably because they started deploying this valve at this level, the patient suddenly needs a temporary pacing wire. Anyway, they got completely fed up and said, okay, I'm swapping the valves. It's rather an expensive thing to do, but that's what they did. And now we have, with an ACURATE Neo 2 marker, right in position, sitting right nicely on the outer curvature, using the wire better, completely stable, no occlusive phase, just open the upper crowns, it's super stable, you can leave the pigtail where it is, implant the valve, thanks very much, the pigtail's outside the valve, you get really good final aortogram showing the deployment of the valve. So that's a very good setting in which to use it. This is a slightly more extreme horizontal aorta, where again you can see the flat valve sitting right on the greater curvature is really useful in this setting to allow you to deploy the valve in what is a slightly uncomfortable anatomy. Valve in valve, I think this is a setting where the ACURATE Neo has been underused so far, and for kind of similar reasons. This was a man who we got called in to do this on one Sunday morning when a colleague said this man is dying of torrential aortic regurgitation from his surgical bioprosthesis. I don't think he's going to make it unless we can fix it quickly. So the team came in on the Sunday morning, and what was the reason we used the ACURATE Neo here was because of the enormous pulse pressure difference and a sense that we were going to have slight difficulty controlling the other supraannular valve system in that setting, particularly with that occlusive phase as you go through the opening up of the valve. So here, this was used under conditions of very rapid pacing. This was early in our use, but we thought this valve would be ideal for this approach. And you can see it sits extremely stably despite the very high pulse pressure width in this patient with torrential aortic regurgitation. It's a little lower than it needs to be in this particular setting, but actually it doesn't really matter. It's done the job.
Well, David, what matters is that the upper crown sits just on top of the commissural post. Yes,
yes.
That's the only thing that matters.
Exactly. Yeah? So, we have a very nice result. We have complete abolition of the aortic regurgitation. So, and that worked very well for him. It's also worth mentioning that it can be used in TAV in TAV. Of course, although we talk about this a great deal, hardly anybody's done any cases, or at least more than a handful. We do about 4 a year at the moment. But anyway, here's a reasonable setting. And again, we've tried to do exactly the same, which is the marker is much higher here because we're looking to land the upper crowns at the upper margin of the the S3. And of course, we're going to be using the skirt of the S3 as a neo skirt. So despite the fact that it's in mid-valve there, it's going to give you a very nice complete elimination of the aortic regurgitation. Finally, aortic regurgitation. Yes, of course, we have some platforms now that are available dedicated for this, but actually this system works really, really well. Here's a slightly horrible looking aorta, if you could just ignore that for a bit, and just look at the aortic regurgitation. Again, if you pace fast, you get very good stability. You need to oversize, of course, by about 20% on a linear basis to make sure that the valve continues to try and push outwards, directly outwards, at 90 degrees to the blood flow, because then it will stay in position. And we've done about 30 of these cases, and cross fingers, I shouldn't say this, but we've never had one embolize in either direction yet. Good, stable position despite the adverse hemodynamics. Open the upper crowns, open the top. Again, this is the old version. This is the first version. And I put a couple more on here just in case you thought he's only done that once, and he was pleased with it, so he showed it to us. No, we've done it lots of times. It's our go-to approach actually for pure aortic regurgitation. So long as the annular diameter is less than 25.5, you can put in the big valve. So here's another couple of cases doing exactly the same. And I think this is something which various people have taken up, and maybe with the dedicated platforms won't be used so much, I don't know, but it actually works extremely well for this indication. Again, this was an old one. Okay, so in conclusion, I think the ACURATE Neo is highly suitable. I would say it's not really a workhorse valve, or at least it hasn't been. Maybe Prime will be different, who knows? But it's really, really suitable and ideally suited for us for about 30% of our cases. So smaller annulus, less heavily calcified annulus, maybe the fibrous AS that we see in women particularly. It's very good in horizontal aorta. It's certainly something that could be considered and is very effective in valve treatment, and finally in pure aortic regurgitation. So I think it is a valve platform that is extremely versatile and can be used perhaps more widely than its limited label statement says. Thank you.
Thank you.
Excellent presentation, and quite courageous cases too, some of them. Can I ask you now, with the Prime XL, the 29mm valve, what would be the upper limit of annulus size for an aortic regurgitation case for you?
Yeah, I'll have to do the maths then, because it's 29 minus 20%, so it's 25, it's 29. So it's 32 at the bottom of the 29, is it?
Yeah.
Yeah, so it'll be 27.7, I think.
Okay.
Yeah. That would be the maximum.
Well, just two small comments. I mean, of course, I agree. We do very much patient-tailored choice of valve because we have multiple platforms. I think of the first slide, which I did like, that's your own experience and how you felt this platform works best for you. Do you have experience with the Prime?
Not yet.
Not yet.
No.
Yeah. So the first 2 points. So you're concerned about the opening force in larger annuli. I think really this is addressed by the Prime. Sorry, because what they did is engineerily, by taking away the free cell and making it actually with the radial force that's completely circular. What they did, the engineers, is they brought the radial force. They knew that from the small to the medium to the large, they lost radial force.
Yeah.
Yes.
Yeah.
What they did is by taking away the free cell and manipulating the nitrinol further, they brought all the radial forces from the medium, the large, and the extra large to the same level as the small. So that's maybe, and I feel, and I think that's Andreas' feel as well, that this radial force issue I was also concerned with the Neo 2 for the large ones, was not my first choice for sure not. Yeah. I think this is addressed with the Prime. Yeah. And then the other thing, the other concern about more severe calcium leaflet calcifications, well, I think that is really perfectly addressable with proper predel. And then I mean, I'm not scared of doing ACURATE in severely calcified cases. but I will do a double tap predel. You know, I will repeat my predel, and doing this, I can have a proper implantation. Then I maybe still need in 35-40% pulse, but you can definitely do it. Yes, and with very good outcomes.
Yeah, no, I mean, I don't doubt it, and I suspect that, you know, Prime will expand our repertoire in Brighton, and maybe some of what we do is simply related to, you know, sharing the love amongst the various manufacturers, which you do have to do.
Yes. Okay, I think by that, maybe Andreas, you do some final words on this session?
Yes, so we have been discussing about the ACURATE platform, and we have been discussing about the, we can say it in Europe now, the prior platform, the NEO2, with the IDE trial with some surprising results. But we have also learned that the expansion and under expansion is not only important in stents in the coronaries, for example, but also actually in these stents that we implant in the aortic position, and that has regained importance now, and I think everybody is looking for it more than before, and that might be helpful also actually for other valve platforms. And then we've been discussing about the Prime platform, which is relatively new. It's rolled out right now all across Europe, where the initial data seems to be very favorable. We'll have larger data presented from a European registry at EuroPCR, for example, so we'll learn much more about the Prime, how much this added radial force adds to the final result for the patient.
Thank you, and further good meeting to all of you.